14 years ago, I broke down a colleague's door to find her dead in the bath. She'd taken her own life. A year later, I was called to the cardiac arrest of a young mother, the daughter of a theatre nurse. Everyone involved in her resuscitation knew her personally. She died from a series of medical errors. This year, the World Health Organization stated every minute 5 patients will die from unsafe care. Medical error has been reported in the British Medical Journal as the 3rd greatest cause of death, yet we've designed our hospitals on the premise that as doctors and nurses we don't make mistakes. But we're human. Just like everyone else, we make mistakes all the time. 4 years ago, I tried to introduce an obvious safety intervention. Eventually it was voted in. However, the deputy head of department, who was against the initiative, resigned. To coax him back, the initiative wasn't implemented. It still hasn't been. Voting on the initiative was illegally scrapped from the departmental minutes. Then I was pulled into a room and bullied for an hour. The head of department looked me in the face, pointed at me and said, "I don't care who you are or what you do, but if you do anything like this again, you are out." We don't stand a chance. Picked off one by one in an industry perhaps too ashamed to change. For healthcare to improve, we need to work differently. Hands up if you haven't read this yet. The human brain is amazing. Yet what if I told you you read the top line wrong? And as a result, a patient died. We work in a high-risk industry. You'd be extremely upset. You may be reprimanded. What else? Information about what happened would be passed up a chain of command, far removed from the event, and there'd be meetings. There may be a root cause analysis. We may create a policy or education program or send out an alert reminding staff to read the sign properly. We may do all of these and expend a lot of energy and money in doing so, and we will have wasted our time, because another doctor or nurse will come along and read the sign incorrectly, and another patient will die, because what we should have done was change the sign. Ergonomics is about designing the workplace and the equipment in it to accommodate for limitations in human performance. It's about changing the sign. Are there thousands of lives to be saved simply through respecting and designing for our human limitation?
After heart disease and strokes, medical error has been reported as the 3rd biggest cause of death globally. The exact figure is difficult to estimate because error reporting in healthcare lacks transparency. But mistakes made in hospitals are leaving patients worse than when they went in. A group of medical staff decided enough was enough and began to agitate for change. Communication errors have been identified as the root cause of the majority of mistakes. Staff in operating theatres can work with hundreds of different colleagues between multiple hospitals, and their faces are covered, so in the midst of an emergency, precious seconds can be lost when clinicians don't know or can't remember the names of their colleagues, which can lead to lack of accountability, wrong equipment used, wrong drugs administered, and so on. To improve communication and reduce mistakes, the answer was remarkably simple. To immediately identify individuals and their roles, we began writing our names and roles on our scrub caps. It was a simple act which changed the culture of the theatre from anonymous to collaborative. Suddenly, it was easier to coordinate, to be more accountable and efficient. With the help of a hashtag, the idea began to take off. Medical staff globally joined in. Some even started printing their own name caps. The world sat up and took notice. What started as a simple idea among a bunch of so-called rabble-rousers has grown into a game-changing movement which is saving lives around the world.
It costs nothing to implement. It's obviously beneficial to patient care. So why isn't it already the norm? Surgeons only know 44% of staff names in their operating theatre. Not surprising when we realise as humans we're very poor at remembering names. Name and role caps increase name recall, reduce confusion, and increase the propensity for staff to speak up. They improve communication, morale, teamwork, and ultimately improve patient outcomes. So if it's not evidence or cost preventing us from displaying our names, what's the most likely thing which will lead us to make this positive change for patient care?
To answer that question, we set up a hidden camera experiment to see if this woman would stand up at the sound of this tone, simply because everyone else is. You might be thinking you'd never go along with this. Or would you? After just 3 beeps, and without knowing why she's doing it, this woman is now conforming perfectly to the group. But what happens if we take the group away?
Elaine, please.
Okay, now she's alone. The crowd is gone and nobody is watching her, except our hidden cameras. What do you think she'll do? She's now conforming to the rules of the group without them even being there. Now, watch what happens when we introduce another outsider who doesn't know the rules.
For a noon appointment. Have a seat and they'll be out in just a couple minutes. Great, thanks so much.
Everybody was doing it, so I thought I was supposed to.
Think she'll teach the new guy what to do? We kept the cameras rolling as more unsuspecting patients arrived. And slowly but surely, what began as a random rule for this woman has now become the social norm for everyone in this waiting room. Here to explain what's going on in their brains is Jonah Berger of the University of Pennsylvania.
This sort of internalized form of herd behavior is part of what we call social learning. Starting at a very early age, when we see members of our group perform a task, our brains literally reward us for following in their footsteps.
When I saw everybody stand up, I felt like I needed to join them. Otherwise, I'm like excluded. Once I decided to go with it, then I felt much more comfortable.
Conformity is how we become socialized, but it can also cause us to develop bad habits or repeat past wrongs.
And it's why even this rebel, who wasn't standing for any of this nonsense, eventually joined the ranks. And the only thing more shocking than seeing how easily conformity affects the way you act is that similar forces are subconsciously shaping the way you think right now.
We're very strong social conformists. The thing most likely to lead us to wear name and role caps is through seeing others doing the same. Something else interesting in this group: healthcare workers who will only accept this obvious improvement to patient care if it's made mandatory. Who are these people? What I hope you'll realize is that while this group is relatively small, they're extremely influential. They can stop us from doing something the vast majority of patients want us to do, and the vast majority of frontline staff want to do too, particularly those new to healthcare. So what stops us from doing something we want to do, we know is right, and is obviously better for patient care. Fear. So what is it we fear the most? Perhaps we fear most for our careers and those who impact on them. However, these people appear least likely to accept things which will make it easier for us to succeed. Ergonomic change. Top-down structures nurture competitive conformists into positions of power. Are these the people we pander to as we compete against one another? Because this is what we've been nurtured to do, all the way through school, university, and beyond. Suggests something which gives us a competitive edge, and we welcome it with open arms, even when it costs millions of dollars. And 15 years of evidence and 4,000 studies indicate it's of no benefit to patient care. Yet suggests something which takes this competitive edge away, which makes it easier for us to do our jobs, an ergonomic solution, and we may look for every avenue to resist it. Why? Traditionally, we only had direct laryngoscopes to help guide our intubations. 15 years ago, devices with a video screen and devices allowing both video and direct laryngoscopy appeared. It's important we realize not all video laryngoscopes are the same. You can see the combination of direct and video views is always going to be at least as good and often better than one view alone. Again, this is backed by the data. This simulated difficult airways trial indicated success rates of 98% with the McGrath-Mac, greater than those designed for video views alone. Establishing an airway is pretty critical. Yet perhaps we're not as good as we think we are in achieving this. In this study amongst anaesthetists of over 180,000 patients, of those intubations that were difficult, 93% were unpredicted. Like it or not, as anaesthetists, we're very poor at predicting difficult intubation. Further, the greater the number of times we attempt laryngoscopy, the greater the adversity. Adverse events like desaturation, esophageal intubation, and aspiration. A major review in the UK found 38 deaths over 1 year from failed airway management. Many of these events considered avoidable. Interestingly, Dr. Tim Cook, who presented the NAP4 data, and the staff at his hospital now electively use video direct devices first line for laryngoscopy. They've published this in the BJA. Internationally, many hospitals do the same. Within my own hospital, we've had a McGrath-Mac in every theatre for the past 4 years. I have my own. This stance well backed by the evidence too. I've been performing laryngoscopy for more than 20 years, well before video laryngoscopes hit the market. I consider myself skilled at direct laryngoscopy, yet even those skilled at direct laryngoscopy have higher success rates when a video direct laryngoscope is used. One excuse often given for avoiding video laryngoscopes is that staff may become de-skilled, unable to use direct laryngoscopes if they train with devices allowing video views. A recent study of over 14,000 intubations appears to refute that argument. One would think we'd gift ourselves and our patients with the best chance of successful laryngoscopy, first line, every time. Which brings me to this survey. This went out on social media with this picture and request. The question breakdown quite simple, and depending on the answer to the first question, staff were asked a different stem for the second question. Our main interest was to find out amongst those who use the direct laryngoscope first line if their choice would be different, given immediate access to video direct or video laryngoscopes. The excuse of cost or availability could no longer apply. This is the unfiltered results for the first question, the vast majority of responders using direct laryngoscopes first line. Perhaps an issue of restricted access to the better device. Unfortunately not. Do we do things because that's the way we've always done them, at the expense of optimal patient care? Do the top-down structures of healthcare resist initiatives which are better for our patients? Healthcare is an extremely emotive profession. To suggest, particularly to our superiors, that we do something differently can be highly offensive. Do we become conditioned and develop siloed beliefs that perpetuate throughout our specialties and industry? One would hope these beliefs disappear as new staff come into a specialty, people more willing to accept a different, better way of doing things. That's what I believed, until the results came back. Irrespective of being new to the profession, anaesthetists were just as likely to choose direct laryngoscopy first line, and just as likely to stick with their decision when the better devices are available. Same with intensivists. In fact, the only group who appeared willing to do the right thing, to do the best for patients first line when given the choice, were paramedics, particularly those new to the game. What strikes me is that paramedics have had a different career path. Are they more accepting of their human limitation? And does this lend them to do the right thing? So what is it that will lead us as doctors to do the right thing, make us change, realign us and drive us to, first and foremost, do the best for patient care? It doesn't appear to be evidence or cost. Perhaps it's something else. Allow me to digress. Anaesthetist Dr. Jen Dixon from Melbourne, Australia tweeted this just over a year ago. Confusion about the internal cardiac arrest phone number within hospitals. It differs depending on which hospital you're in. Standardizing this time-critical number provided a great opportunity to demonstrate how effective a networked team approach can be in delivering change and improvement. We crowdsourced the data, finding at least 51 different numbers across Australia, and discovered elsewhere in the world others were trying to do the same. The UK standardised at 2222 10 years ago, and there's a push to standardise throughout Europe and internationally. Dr. David Whittaker, the main driver behind this. So we introduced him to our Basecamp group, a great project software platform allowing documents to be stored. Anyone in the group can pitch in at any time. We might, for example, work together on a message to send out further. This infographic sent out on social media. As well as social media, we've great links with mainstream media too. We hit the front page of the Sydney Morning Herald. And all the time we continue to develop strong connections with healthcare governance. And within a year, we'd managed to achieve something which took the NHS twice the time and cost them millions. All this from a single tweet. Ripples of change become waves of improvement. We'd like to drive this change internationally and believe we can. But what is it that makes a hospital introduce change? Perhaps something social psychologist Malcolm Gladwell illustrates through this man. This is NBA star Wilt Chamberlain. In 1962, he scored 100 points himself in a single game of basketball, a feat that's never been equaled. What's fascinating, though, is Wilt made 28 points from the free throw line, another unbeaten record. Fascinating because Wilt was useless at free throws. However, the season before, he was persuaded to change his style and throw the ball from between his knees like this. His success rate took off. What intrigued Gladwell most was the following season, Wilt reverted to the regular overhand technique. His success rate plummeted, yet despite this, he persisted with the overhand technique for the rest of his career and never had a high score again. In his autobiography, Wilt Chamberlain regrets reverting back, however felt he had to, because in his own words, he didn't want to be seen as a sissy. He put his own reputation first, and in doing so, let his team down. A trait which can be common to us all. Question is, would you let your reputation get in the way of doing the right thing? Or better still, can we create a system which aligns our reputation with doing the right thing, which aligns our reputation with providing the best in patient care? Well, yes, we can, and we have, and it's been used with great success in driving emergency number standardization, displaying those hospitals which have standardized in green, those for which we've the details but haven't standardized in amber, and those for which we haven't received the details in red. Scoring in this way encourages transparency, a better score where the information's available. Where required, we can apply this technique to any project. Does your hospital support staff wearing their name and role? Does your hospital provide video direct laryngoscopes in every theatre? Just as domestic equipment has been rated for years, collaboratively we're able to rate the healthcare equipment and systems we interface with. Institutions given an aggregated score based on the systems in place. These scores give impetus for hospitals to improve and move up a league table. This is the Learning from Mistakes League, a subjective table based on frontline feedback. Working together, We're making this objective, driving safety improvements throughout healthcare. Working together, we'll change this and start heading in the right direction. And working together, we'll create the best environment for patient care. Thank you.